Hello guys, this is Calvin here. I'm doing my second year MBBS right now, and today our topic will be multiple myeloma. So this is one of the most important topic in pathology in our MBBS second year, and also it is asked in Vivas, it is asked as essay question, it is asked as short answer, and it's most of our universities. So without wasting your time, I want to move quickly into this topic. So what is multiple myeloma? And before I start talking about the definition, pathogenesis, and lab diagnosis, everything, I just start the multiple myeloma with a story of understanding. So definition. So for this understanding of definition, I want you guys to listen carefully to what I say. Now there is a plasma cell. Now there is a plasma cell in our body. So this plasma cell is actually a rebel plasma cell. What is rebel? Like it is gonna multiply endlessly. Now there is a plasma cell in our bone marrow. Now there is a B cell. Now this B cell is actually maturing. It is now getting differentiated, and now this is becoming a plasma cell. The plasma cell in our bone marrow, what it is going to do? It is going to produce the antibodies. There is one plasma cell among these all plasma cells. Particular plasma cell is now thinking that I do not want to die. I do not want to die. So what it does? It is actually going to multiply. It is actually clone itself. So this plasma cell, it is actually thinking it is not going to die and it is actually going to be immortal. So that is why it is producing multiple copies of itself through cloning. It is cloning itself. And now what happens? The plasma cell is actually antibody workers. What is antibody workers? Like they are going to produce the antibodies. So particularly in our bone marrow is like a factory. So there are different B cells which is undergoing maturation, which is undergoing differentiation to produce the plasma cells. Now every plasma cell will produce different antibodies. Like one plasma cell will produce different antibodies. Now what happens? There is one single plasma cell among the all the plasma cells. It decides not to die. It is actually undergoing the cloning. Like it is dividing itself endlessly. It is multiplying itself. So there is going to be what? In the bone marrow, the factory is now filled with one particular identical plasma cell. It has been filled the bone marrow. It is now filling the bone marrow. And now what happens? As the plasma cells are producing the antibodies, so there will be only one particular type of the antibodies is elevated. जो भी होगा, like any plasma, any antibody can be any antibody that will be increased over here. Now, the plasma cell neoplasm, this is the malignant monoclonal proliferation of the plasma cells in the bone marrow. That is what I want to say. So one particular plasma cell is actually multiplying endlessly. So there is endless multiplication. It is dividing, it is cloning itself. And now the plasma cell neoplasm will produce a monoclonal immunoglobulin that is going to be the M protein. Now, what happens? It is going to cause the skeletal destruction and systemic organ damage. So, this is all about your definition. Now, talking about the pathogenesis. So, as I told, normally in normal body, what have normal physiology? Let's talk about normal physiology. Our bone marrow is here. I have my bone marrow. You have your bone marrow. Yes or no? Now, our bone marrow is here. In this bone marrow, what happens? There is B cells. The B cells are undergoing maturation and differentiation. Now it produces the plasma cell. Yes or no? Now this plasma cell, as we know, it is going to be antibody workers. That is antibody producers. These plasma cells are. Now this plasma cells, like where the fault occurs. Now, so let's talk about the fault. Okay. So now the plasma cells are there. The plasma cells are now producing the antibodies. This is the normal thing that is happening in our body, inside our body. Now, it originates in the post-germinal center plasma cells with the immunoglobulin heavy chain rearrangements. Heavy chain rearrangement. This is the thing. Like immunoglobulin heavy chain translocations will occur. Originates from post-germinal center B cell. And now what happens is it is going to cause malignant plasma cell. So there will be increase in the plasma cells. Now what happens? Our bone marrow has stromal cells, yes or no? So stromal cells are there in our bone marrow. Now this particular type of the plasma cells which has been increased in number. The plasma cells are there, yes or no? Now those plasma cells are increased in the number. So when particularly one plasma cell is increased in the number, thinking that I will not die, I have to clone myself endlessly. Now this plasma cells fills entirely in the bone marrow, and this plasma cells comes in contact with the bone marrow stromal cells. Once the stromal cell and the plasma cell comes into contact, there is an interaction between the stromal cell of the bone marrow and the plasma cells. Now there is an interaction, right? So now what happens? The stromal cells will produce a cytokine. The stromal cells in our bone marrow will produce a cytokine, which is nothing but the interleukin 6. Now this interleukin 6 is actually which is actually produced by the stromal cell. It is obviously a cytokine. The interleukin 6 is nothing but a fuel to the clonal expansion. Like it is gonna be a fuel to the plasma cell expansion. It is gonna prevent the apoptosis. How it is actually acting as a fuel to this multiple myeloma, to this plasma cell. It is going to increase the clone cells. Like clonal expansion occurs, it is going to prevent the apoptosis. And next is the tumor cells induce the osteoclast activation. Now, what is osteoclast? Osteoclast means bone destruction. Okay. And osteoblast means bone formation. Normally, in multiple myeloma, what is occurring is there will be inducing there will be like what? So all these tumor cells will induce the osteoclast activation. So simply remember there is stimulation of the osteoclast activity, which means what? There is destruction of the bone. So when there is destruction of the bone, this osteoclast activation will inhibit the osteoblast formation. Osteoblast formation is what? It is the bone marrow formation. It is the bone formation. So now not bone marrow formation, it is the bone formation. So once the bone formation is now inhibited and there is increase in the destruction of the bone, what will happen? There will be bone destruction. So that is why in multiple myeloma, you will have multiple bone lytic lesions. So now comes to the graft features. So just now I talked about what is the osteoclast formation. So osteoclast activation means what? So there is destruction of your bone. So when there is destruction of your bone and there is no formation of your bone, so excessive bone destruction will be there. What is actually there in the bone? Bone as calcium in it, yes or no? So when there is calcium in the bone and there is destruction of our bone, there will be hypercalcemia. So calcium level is increased in our body. That is why C comes, graft. And then what happens? Renal failure. Now, there is something called Bence-Jones proteinuria. We have studied in our first year biochemistry about multiple myeloma, Bence-Jones proteinuria. So there is something called as Bence-Jones protein in our body. So what happens? There is renal failure. So there is a renal dysfunction because of the M protein. There will be amyloid deposition and there will be rising in the creatine level. There is oliguria. So the Bence-Jones proteinuria will also be there in case of the multiple myeloma. So this is very important thing that you have to write in your graph features. So there is going to be hypercalcemia due to the osteoclast activation, which suppresses the osteoblast formation. Osteoblast is bone formation. Bone formation is now suppressed, but destruction of the bone is there. Bone has calcium in it, so hypercalcemia is seen. Renal failure is due to the M proteins, and due to the M proteins get into the filters of our kidney, and there is Bence-Jones protein. Proteinuria has also been seen. Anemia, as I told, now the plasma cells, the bone marrow is a factory. One plasma cell is the worker. Now this worker is actually cloning himself into many. Endlessly he's cloning himself and he's producing enormous number of the antibodies in our body. Now this plasma cells is now entirely filled in the bone marrow. There is no place for other cells like the RBCs to be filled. So there is no place for the RBCs to be filled in the bone marrow. So obviously there will be anemia. So this anemia will also be there, and then bone lesions. That is, as I told, is osteoclast activation is more than osteoblast. So destruction of the bone is there. So there will be like lytic punched out lesions in the skull, in the spine. Severe bone pain will be there. See, someone have hit it, like punched out. Someone has punched your bone. There is like many holes in your bone. Like that, it will be like it is very painful. You will have severe bone pain. You will have like punched out lesions, and your skull will be very painful. Your spine will be painful. These are the pathological features that is seen in the multiple myeloma. And next one is the laboratory findings. So in laboratory findings, we have the something called as SPEP. That is the serum protein electrophoresis. And now this revealed the sharp M spike. Normally what happens whenever there are different type of plasma cells in our bone marrow, it will produce different type of antibodies in our body. Yes or no? So there are different types of plasma cell, different type of antibody produced. The graph will look like what? It will look very smooth. The graph will look smooth. But in the case of multiple myeloma, there is only one plasma cell which is gonna clone himself. It is multiplying endlessly, cloning himself. Now this plasma cell, it is actually antibody workers. antibody produces. So this particular one plasma cell which has cloned themselves multiple times, it is producing the one particular single antibody, and therefore the graph will show like an M spike, and that is why we see that is seen in the serum protein electrophoresis. And urine, as I told, there will be Benz-Jones proteinuria, free light chains, which is not detected by the standard dipstick, and peripheral smear shows Rolex formation. Rolex formation is like RBCs will stack like coins. I think you have we have seen in our pathology labs, right? Like in histopathology, cytopathology, we would have seen in cytopathology. And there will be obviously increase in the ESR level. Erythrocyte sedimentation rate, ESR, will increase in any kind of inflammation in our body. And CBC, there will be normocytic, normochromic anemia. There is nothing wrong with our RBC product, RBC. There will be normocytic, normochromic anemia. Only thing is there is no place for the RBCs in the bone marrow because of the plasma cells getting all the place occupied by that. The RBC, the plasma cells just occupies all the places in the bone marrow. So there is no place for the RBCs. And that is the reason we have normocytic, normochromic anemia. And all these things are the laboratory findings. The next one is the diagnostic criteria. Bone marrow clonal plasma cells, monoclonal protein, very important. You have to write in your paper, monoclonal protein M present. That is, the M protein is present, which is detected by the serum protein electrophoresis. And then myeloma defining events. We have the CRAB features, that is hypercalcemia, that is increase in calcium level, renal dysfunction, and anemia, and then multiple bone litigation or bone lesions. Yes, you can write. Mainly, which is going to be like punched out bone lesions, multiple bone lesions will be there. And the skull, the bone, and all these things will have enormous amount of pain. That is seen in that is the pathological features. So all these things are the diagnosis thing. And then differential diagnosis, monoclonal gammopathy of undermined significance, MGUS, monoclonal gammopathy of undermined significance. Now what happens over here is M protein will be less than 3 gram per DL. So what happens is, like, simply in simple words I'll explain you. There is M protein that is going to be less than 3 gram per DL. That is fine. Now the marrow plasma cells is less than 10%. That is also fine. There is no CRAB features. Now the patient is asymptomatic. But there is one plasma cell which is found at the peripheral smear, but it is not destroying, it is not producing any kind of CRAB features. Like it is not going to affect on anything. It's like it is like an asymptomatic. Like one plasma cell is found in the peripheral smear, but it is not affecting in that way. That is the MGUS. So you do not find any CRAB features over there. It is asymptomatic, and then it is commonly in elderly. Above 50 years of age, 1% risk of progression per year. And smoldering myeloma. So whenever you write about myeloma in your paper, in your pathology paper as an essay question or whatever things, you have to mention about the differential diagnosis, MGUS, also about the smoldering myeloma. Smoldering myeloma can be asked as a short answer separately. So smoldering myeloma is nothing but an intermediate state. Okay, so now the M protein will be more than 3 gram per DL. The marrow plasma cells will be more than 10% and it is less than 60%. There will be no CRAB features. CRAB features are nothing but it is going to be symptomatic. So once a CRAB features comes in multiple myeloma, that is going to be symptoms of the multiple myeloma. There will be hypercalcemia, renal dysfunction, end organ damage will be there. Anemia will be there, and then bone lesions will be there. So here also there is no CRAB features. Higher risk of progression to active myeloma. So this is very important. Higher risk of progression to active myeloma. Smoldering myeloma is like asymptomatic thing, asymptomatic myeloma. And this one, we have the Waldenstrom, that is lymphoplasmacytic lymphoma, where you have the IgM spike, you will have macroglobulinemia, you will have the IgM spike. See, there are only one particular type of the immunoglobulin is usually elevated in the case of multiple myeloma, which is going to be IgM, or it can be Ig. So it is like you have mostly in multiple myeloma, what happens is mostly one type of the immunoglobulin will always be elevated. That is going to be IgM. That is in almost about 50 to 60% of the multiple myeloma cases, you will have this particular type of the immunoglobulin, that is IgM. There will be IgM spike. And next one, around 20 to 30% or 25%, I'm not sure about that. 20 to 30% you can consider. That is in about 20 to 30% of the cases of multiple myeloma. IgA will also be elevated. But most commonly elevated immunoglobulin will be IgM. And there is mixture of the B cells and the plasma cells over here. There is hyperviscosity syndrome. So you will have visual changes like blurring of the vision, dizziness, bleeding, all those things. And in the Waldenstrom lymphoplasmacytic lymphoma, this is a lymphoplasmacytic lymphoma. Here there will be no lytic bone lesions and there will be no hypercalcemia. So graph features doesn't occur over here, doesn't occur over here, doesn't occur over here. So in all the three, there will be no graph features. Remember this. Next, we will talk about the complications. So in complications, we have the pathological fractures. So as the osteoclast activation is there is destruction of the bone. The what happens now? And there is osteoblast inhibition. So osteoblast means formation of the bone. Osteoclast is destruction of the bone. In multiple myeloma, there is only destruction of the bone. That is osteoclast activation, which suppresses the osteoblast formation. What happens over here? There is excessive bone destruction. This will lead to the fractures, mostly in the vertebrae, ribs, and the skull. Risk of the spinal cord compression, which is a medical emergency. Then we have renal failure. Renal failure is direct toxicity of the light chains. The light chains are the Benzstone gas. Benzstone's protein. So hypercalcemia. Hypercalcemia is also one of the cause of renal failure. And then you have amyloidosis. Amyloidosis, hypercalcemia, Benzstone protein, everything will lead to renal failure. And then infections. So as what happens, so the leading cause of the death is the infections because there is decrease in the production of the normal immunoglobulins. So what happens, only one particular type of the immunoglobulin has been elevated. Other immunoglobulins like antibodies will not be there, right? Only one single antibody is elevated. So hypogamma globinemia and neutropenia will also be there. So this is one of the cause of infections, and infections is the leading cause of the death. And amyloidosis AL type, which is nothing but it affects the heart, it affects the tongue, kidneys, and the nerves. And next one is this one, monoclonal protein. So monoclonal protein is nothing but IgG, as I told, it is seen in most of the multiple myeloma cases, about 50% I have told. So it is like 55%, and IgA it is 25%. IgA is 25%. Production of excess monoclonal immunoglobulin M component and excess free light chains, that is kappa or gamma, excreted in the urine as Benzstone's protein. So excess free light chains. What are the excess free light chains? Which is going to be kappa and gamma, which is excreted as Benzstone's proteins in the urine. So you have one criteria, Benzstone's proteinuria. You have the monoclonal immunoglobulin excessive production, M spike will be there. IgG, which is the most commonly elevated in immunoglobulin, that is in multiple myeloma, around 55% cases of multiple myeloma. And next will be the IgA, which is 25%. And the test which is used is the serum protein electrophoresis, which reveals a sharp spike in the M spike, sharp M spike in the gamma region, which confirm with immunofixation. So this is the albumin, alpha 1, alpha 2, this is the beta, and this is the gamma, which is the M spike. So you see there is an M spike over here. Yes or no? So this is the thing. And now, as I told, there is like punched out lesion. So someone is punching you on your bone, on your skull. How painful it would be. So you have the multiple punched out lesions over here. As you see, as you can see over here, everywhere you can see. Can you see this? The punched out lesions over here. Look into this diagram. So all as osteoclast activation. So from the beginning, I'm repeating the same thing, like osteoclast activation. Clast is the destruction of the bone. So there is excessive destruction via the tumor stromal signal. So osteoclast activation, destruction of the bone is there, and osteoblast activity is now suppressed. So whenever there is osteoclast activation, there is suppression of the osteoclast activity, which will lead to impaired bone formation and it is repair. And the lytic punched out lesions. So what happens is like so whenever there is a question like punched out lesions, you have to immediately think about the multiple myeloma causing severe bone pain and fractures. So it is actually very painful, and fractures is the complications. So quick revision, pathogenesis to the diagnosis. So there is a malignant clone. Obviously, you guys have to see the concept story everywhere. Like I have mentioned, one rebel cell triggers a chain reaction, clones toxic proteins is produced, melting bones, and then system collapse. So this is something that you have to understand. For your understanding, I have written like from every side you can see the concept story. and there is a malignant clone is there. Now there is a secretory product. Now there is a bone destruction and then end organ damage. End organ damage, you will have the features of the crab. That is the hypercalcemia. You have the renal failure. You will have anemia, and then the bone lesions are there. And malignant clone, how it is occurring, originates in the post-germinal center where a plasma cell proliferation occurs. There, what happens? Which is being driven by IL-6. Interleukin-6 is acting as a fuel. It prevents the apoptosis. It increases the survival rate of the tumor cells, and also it is expansion. The clonal expansion is being promoted by the interleukin-6. And next one, the secretory product. What is secreted? M protein is there. M spike, that is in the gamma region. The free light chains, that has been excreted as Bence-Jones protein in the urine, Bence-Jones proteinuria. Then we have the bone destruction. Bone destruction, osteoclast activity is increased and osteoblast is suppressed. That is, the production of the bone is suppressed, destruction of the bone is increased. And then end organ damage, you will have hypercalcemia due to bone lighting. Due to the destruction of the bone, there will be hypercalcemia. And then you will have renal failure. You will have anemia because there is no space for the RBCs in the bone marrow. There will be anemia, and then bone lesions will be there. So malignancy defined. Multiple myeloma is a clonal plasma cell malignancy defined by the production of M protein. So this is the final take home. You have to look into the important things that I have told you. Calcium, renal failure, hypercalcemia, renal failure, anemia will be there, and then you have the bone lesions. And then you have the key investigation. There will be M spike on the serum protein electrophoresis. This M spike is due in the gamma region. If you look into my video, you will I have mentioned the graph over there. Gamma region, you have the M spike. Everything is clearly mentioned in my PPT. And this is actually the M spike on the serum protein electrophoresis is the diagnostic hallmark. So this is very important. So this is, I have a very easy thing. Last one, the chart, you can have it, a screenshot, as a screenshot, you can have it. Just for a very quick revision, you can just revise entire multiple myeloma. So the bone marrow is acting like a factory. Okay. So now there is a factory hijack. The plasma cell is there is a plasma cell which is now what? One rebel cell. This plasma cell is like one rebel cell will be there. And now this rebel cell takes over the entire bone marrow. There will be M protein, overproduction of the M protein. There will be M protein spike will be there. Now this there will be interleukin 6. This is interleukin 6. How it has been produced? Interleukin 6 is produced because there is increase in the plasma cells. In our bone marrow, there is increase in the plasma cells. Now, these plasma cells have been coming in contact with the stromal cells of the bone marrow. So, our bone marrow normally have stromal cells, yes or no? Now, the plasma cells come in contact with the stromal cells. This interleukin 6 is being produced by the stromal cells of our bone marrow when the plasma cell gets in contact with the stromal cells of our bone marrow. Now, interleukin 6 is a cytokine. This cytokine interleukin 6, which is actually fuel for the clonal expansion. Like it increases the multiple myeloma. It is like a fuel. Okay. So what are the effects of multiple myeloma? You will have the calcium release, bone destruction is there, punched out lesions will be there. So you can see there is punched out lesions. There will be enormous amount of pain, like fractures will be there. Bence-Jones proteinuria will be there, and anemia because of decrease in the RBC production, because there is no space for the RBC formation. Only the plasma cells occupies the entire bone marrow. Key diagnostic feature, hallmark, I have told you, M spike. The serum protein electrophoresis, you will find the M spike in the gamma region. This is the diagnostic feature, the most hallmark feature of the multiple myeloma. In urine, you have Bence-Jones protein. Bence-Jones protein are nothing but the gamma and the kappa. These two light chains will be eliminated, excreted in our urine as Bence-Jones protein. So there will be Bence-Jones proteinuria. And then bone marrow, you have increase in the plasma cells, and X-ray will show light-tick lesions it shows. And now exam type, you just have to remember the CRAB criteria. Differential, you have to remember Waldenstrom, and then metastatic bone, and then MGUS. That is, all these things I have explained you. So I don't think so. You have to think a lot in this. Just, I hope I have made this clear for you guys. So I hope multiple myeloma is very clear for you, and have a look at this chart at last, and go after this lecture. Please go sit with your Robinson book and read it once again, because it is one of the very important topic. And I hope I have made this clear for you as much as possible. And thank you so much. We'll see you again in next class.